Now we're going to see ventricular fibrillation. The trace that we're going to see, the strip is like a white complex of the QRS and totally irregular, so something like wherever it be, it has no sense. Here, not to be confused with ventricular fibrillation and dorsal the points that is up and down, that's the other thing. So in ventricular fibrillation, the patient could have a syncope episode, decrease, or that is the absence of a pulse, or we cannot catch the blood pressure. So it's the classical patient that is the victim lying on the floor, non-responsive. What do we do? Basic life support. Here we're doing the compressions, 5 cycles of 30 compressions to breaths. And then the monitor arises. We plug the monitor and we see that the patient has ventricular fibrillation. What do we do? First we will shock the patient, because this is a shockable rhythm. This is a unsynchronized cardioversion, the same as saying the fibrillation, because here there is nothing to synchronize with, because the ventricle is just doing like this. So the best initial thing would be the shock. Now that we have the defibrillator, we will shock the patient and resume CPR immediately. Then we will check again. If we see that the patient continues on ventricular fibrillation, then we will give epinephrine and CPR. Oh, also refer, we shock again. We shock again, and now we add epinephrine and resume the CPR. The reason for which we are adding epinephrine is because in the case that this does not resolve and the patient continues on ventricular fibrillation, this next time that we are checking, this epinephrine is going to increase the likelihood that this shock can make the good day. So here we will give the shock. If we see that the patient is on ventricular fibrillation, we will give the shock. And now we are alternating between epinephrine and amiodarone. So we will give amiodarone and the 5 cycles of CPR. We will check if the patient continues on ventricular fibrillation, then shock again, and now epinephrine and continue CPR. So we have intervals in which we are giving the 5 cycles of CPR and some intervals between the 5 cycles of CPR. In these intervals, we are checking the read here, checking the read. If it is a shockable read, we shock the patient and we give medications in order to increase that. If after the CPR, the immediate CPR, when we check it continues on being ventricular fibrillation and we need to give another shock, the patient can make it. And we are alternating between epinephrine and amiodarone. Epinephrine, we can give it until three times. So we have epi, amiodarone, epi, amiodarone, epi, amiodarone. Amiodarone. Between one epinephrine and another, we have like 3 to 5 minutes, and we have 2 times giving 5 cycles of 30 compressions and 2 breaths. So if each 5 cycles of CPR lasts like 2 minutes, actually we are giving epinephrine almost a little bit more than 4 minutes, because we need to count these intervals. Alright, so the first doses of epinephrine can be substituted by vasopressin, so it could be epinephrine amiodarone, epinephrine amiodarone, epinephrine amiodarone, or vasopressin amiodarone, epinephrine amiodarone, epinephrine amiodarone, or epinephrine amiodarone, vasopressin amiodarone, epinephrine amiodarone. The doses are, for epinephrine is 1 milligram, and for amiodarone is 300 milligram. The best is to use amiodarone but the most available is lidocaine. So we can do it either with amiodarone or lidocaine. So for the ventricular fibrillation, we shock the patient, give medications, and resume CPR. The causes of ventricular fibrillation could be most often associated with ischemia, like a myocardial infarction, also could be associated with asystole, other cardiomyopathies, and lastly some cardiac defects. These cardiac defects could be, for example, the ones that lead secondary to the cardiomyopathy.